everyone. Myself, Dr. Priyanka, and I'm one of your mentors for Study EFOG. So today we are back with the RRR series, YouTube series, where we will be discussing important questions regarding each module. So our today's module is on our module is antenatal care, and we will be discussing important SBS and EMQs regarding the antenatal care module. So do like, share, and subscribe StudyMEDIC channel, and also press the bell button icon to get the updates on recently added videos. So let's start. So always remember that success is not final, failure is not fatal, and it is the courage to continue that counts. So always believe in yourself and keep practicing, and definitely you will succeed. So we will be discussing 10 single-based answers and 10 extended matching questions today. Okay. So coming to single-based answers, so the first question here is, so we will be discussing on the topics of the RH negative pregnancy and antepartum hemorrhage and steroid indications in the antenatal period. So coming to first question, so it's a 30-year-old woman with a previous history of cesarean section, and she had multiple uterine fibroids. So there is a history of previous cesarean with multiple uterine fibroids, and she had elective cesarean section in this pregnancy for breech presentation. Because she had a previous cesarean and multiple fibroids, after the cesarean, there was massive postpartum hemorrhage almost where due to uterine atony, where the estimated blood loss was around 3 liters. So it's a major PPH. Her blood group was found to be RH negative, and then because she had a massive blood loss, she was transfused with group specific packed red cells, and also there was reinfusion of the salvage red cells, and that is intraoperative cell salvage, and also she received fresh frozen plasma, cryoprecipitate, and platelets, and the cord blood group was found to be RH negative. So the question here is, the anti-D prophylaxis should be administered in one of the options if she had the following blood products transfused. So the question here asked is, in which blood products the anti-D should be administered. Okay. So here the answer is RHD positive platelets, that is C. Why answer is C? Because in the scenario, if you can see, she has already received group specific packed red cells. Okay, so she has already received the PRBCs, which are group specific, and there is reinfusion of the salvage red cells. And we know that the fresh frozen plasma and cryoprecipitate, they are the ones which can be may not be group compatible, and they can be given. So there is no anti-D prophylaxis is required if the woman receives RH positive FFP or cryoprecipitate. And for platelets, they should be group specific. That's why the answer here should be RH positive platelets. So here, a dose of 250 international units anti-D should be given to cover 5 adult therapeutic doses of platelets within a 6 weeks period. And when we are going to do the intraoperative cell salvage, here in a non-sensitized woman, the minimum dose should be 1500 international units anti-D. Okay. And this should be, the maternal blood sample should be estimated within 30 to 40 minutes after the reinfusion of the, to see if we need more anti-D. Now coming to second question, here is a 42-year-old woman who is para 4 and she is with preeclampsia. She has a history of preeclampsia and comes to the antenatal clinic at 34 weeks of gestation. So she is preterm. She is asymptomatic with stable blood pressure on labetalol, and the biochemical markers are normal. But the ultrasound shows that there is fetal growth restriction. She is extremely anxious because she had an abruption in her previous pregnancy, and that had led to an emergency cesarean section at 34 weeks. So it was a preterm cesarean due to abruption. So the question here is, which one of the risk factors has the most predictive value for abruption in this pregnancy? Meaning that which is the major risk factor which will determine the risk of abruption in this pregnancy. So what is the major risk factor here? So the answer here is if there is a history of previous abruption in her case. Okay. So she has advanced maternal age, her age is 42, she is multiparous, which all are the risk factors for having an abruption. She is a case of preeclampsia, there is fetal growth restriction. Okay. But the major risk factor here is if they are having a history of abruption in previous pregnancy. So the answer here is E. So what is abruption is when there is premature separation of a normally situated placenta. So meaning that should rule out placenta previa if there is a case of APH and other local cervical causes. So there are other causes of abruption, like there is a history of preeclampsia, or if there is fetal growth restriction, which may be associated with preeclampsia, if there is polyhydramnios, or if there is a short cord, okay, which can lead to premature separation, or if there is advanced maternal age, IVF pregnancy, or if there is an abdominal trauma, okay. But the most significant risk factor is having a previous history of abruption. So if there is one previous history of abruption, the risk is in this pregnancy is 4.4%. And if there is history of two previous abruptions in this pregnancy, the risk goes up to 19 to 25%. Now coming to third question. So here the patient is a 38-year-old para 3, okay, with previous 3 cesarean sections. So she is 38-year-old and she is in her fourth pregnancy. She had previous 3 cesarean sections and she has come for the first antenatal appointment. So she wants to know what is the risk of developing placenta previa in comparison to women who didn't had any cesarean section. So she had previous 3 cesarean sections, so she wants to know what is her risk, increased risk of placenta previa in compared to that woman who did not had any prior cesarean. So here the answer is the more the number of cesarean sections, there is increased risk of having a placenta previa. In her case, it is the answer is D. It is almost more than 20 times. Okay. So the risk factors for placenta previa, that is the placenta which is low lying and it is within the 20 mm, lying 20 mm in the reach of the internal loss is called as a low lying placenta and a placenta previa. So what are the risk factors for placenta previa? They include previous cesarean section where the any condition which will hamper the migration of the placenta from the lower to the upper uterine segment can lead to placenta previa. So in cases like previous cesarean section where scar or a myomectomy scar where the placenta won't migrate upwards, or if there is a multiparous woman, or if there is advanced maternal age, multiple pregnancies where the placenta is like the mass of placenta is large, even in smoking, there is a bit of a placental hypertrophy, which makes the placenta low lying. These are the conditions, and a previous history of curettage and scar make the risk of placenta previa more likely. So here the odds ratio after one previous cesarean section is 2.2, and after two cesareans it is 4.1, and after three previous cesarean sections it goes to 22.4. Now coming to question 4, she is gravid of 4 para 2 woman and she is 32 weeks with history of preterm premature rupture of membrane. So she is 32 weeks. She has had a cervical circulage in this pregnancy at 13 weeks. Why? Because she had previous 2 preterm deliveries, and also she has had 1 second trimester loss. But now she has come with PPRM, but there are no other signs of infection. She is not contracting, and the CTG is normal, and the PPRM is confirmed on examination. The ultrasound scan confirms normal growth, liquor, and Doppler findings. So, which one of the following statements is true with regard to the timing of suture removal, the cervical circular suture removal? Okay. So because she's 32 weeks, so in this case, we are going to give her antenatal corticosteroids, and we can consider delayed suture removal for up to 48 hours for the steroids to act. Okay. So the answer here is C. So we can give steroids and consider delayed suture up to 48 hours, because we can delay up to 48 hours because the scenario says that she is symptomatic for infection and she is not in labor. Okay, the CTG is normal and also the ultrasound is normal. So it can be delayed up to 48 hours for the steroids to act. Because if she goes in labor, so there is increased chance of uterine rupture. And even if there is a NICU facility which is not available, then we can in utero transfer the patient to a higher center. Now coming to question 5. So here you are seeing a nulliparous woman who is 31 weeks preterm in the day assessment unit for a growth scan. She has come for a growth scan which shows that the baby is small for gestational age at 28 weeks. when she was at 28 weeks and having regular scans. Also, the fetal weight is third centile, but the amniotic fluid volume is normal, but abnormal umbilical artery Doppler, okay, which shows intermittent absent in diastolic flow. The middle cerebral artery and the ductus venosus Dopplers are within normal limits. Okay, she had received steroid injections 2 weeks ago, and when she had presented with history of antepartum hemorrhage, which was managed conservatively. The hemorrhage was settled and she was sent home, and the cardiotocograph was normal. So now, what are the most appropriate recommendation and mode of delivery? So here the question is, she is having absent end diastolic flow with the fetal growth restriction. The fetal weight is less than third centile, and now she is 31 weeks. So when we should deliver her? So the guideline says that if it's an absent end diastolic flow, okay, so here they should be delivered by cesarean section by 32 weeks of gestation. So 1 week we should monitor her bi-weekly for the Dopplers, and then we need to deliver her because of absent end diastolic flow by an cesarean section, because the absent and end diastolic or a reverse end diastolic flow babies, they have very high risk of developing hypoxia when we allow them induce them for a normal delivery, and that's why the recommendation is to have a cesarean for absent and reverse end diastolic flow. So this for absent flow, the cesarean should be done by 32 weeks of gestation, and steroids. So she has already received, so no need to repeat again a course of steroids. So the answer is A, cesarean section by 32 weeks. Coming to question 6. Here she is a 28-year-old woman and she has slight lower abdominal pains and a watery vaginal discharge. She has received a course of betamethasone. So here the betamethasone, that is the steroids, how much percent it will reduce the risk of neonatal death? Okay, so the answer here is 31 to 40%. So steroids can be given, it can reduce the risk of respiratory distress syndrome, that is RDS, by 44%, intraventricular hemorrhage risk by 46%, and neonatal death risk by 31 to 40% according to the Green Top guideline on antenatal corticosteroids. Now here a 36-year-old woman who has uncontrolled diabetes and she is 29 weeks pregnant is admitted because of threatened preterm labor. So what is your advice regarding steroids for lung maturity? Okay. So she is 36 years old. She is having uncontrolled sugars and she is 29 weeks pregnant with threatened preterm labor, for which we want to give steroids because in case she needs delivery, so for the fetal lung maturity. But we know the antenatal corticosteroids can cause hyperglycemia, and already in a hyperglycemic woman, it may be a challenge. So, what are the recommendations? Is the answer D and E are both the correct answers, but the single best answer here is answer D. So yes, answer E is correct too. That is, uncontrolled diabetes is not a contraindication to receive steroids. That is also an answer. But what is the single best answer here? Is answer D. That is, steroids are administered with additional dose of insulin and close monitoring. Okay, so both the answers are correct, but we in the uncontrolled diabetic patients we give steroids, but we manage the sugars by the insulin by the sliding scale. Okay. Now, coming to question 8, she is a 32-year-old woman who is 36 weeks pregnant, and she comes to the labor ward because there is upper abdominal pain and slight vaginal bleeding. Okay, which are like she has her two previous pregnancies which ended in cesarean section because of placental abruption, and she has a normal blood pressure and reactive non-stress test, that is NST. So the clinical picture looks like 32 years, she is 36 weeks and has abdominal pain accompanied by APH, that is bleeding. So here, if it's a pain, bleeding associated with pain, which is more likely suggestive of placental abruption, and the patient gives previous two pregnancies affected by placental abruption. In placenta previa, the bleeding is mostly painless. So here the question is, if she had previous two pregnancies affected by placental abruption, so what are the chances of having another placental abruption in this pregnancy? So as we discussed, if there is a one previous history of placental abruption, then there is a risk goes to 4.4% in this pregnancy. If there is previous two histories of placental abruption, the risk in this pregnancy is almost, answer is C, 19 to 25%. Okay. So again, I would like to emphasize on the risk factors of placental abruption. They include hypertensive disorders, that is preeclampsia, fetal growth restriction, polyhydramnios, short cord, advanced maternal age, or a low BMI, multiparous woman, IUI conception, or an IVF, smoking, or and drug misuse, especially cocaine, okay, which is associated with a placental abruption. Now, a 29-year-old woman who has just booked for her antenatal care. She's 29 years and her first pregnancy ended in cesarean section because of placenta previa. Okay. So now what are her odds ratio for a recurrence after a one cesarean section? Okay. So after one cesarean section, the odds ratio is 9.7%. That is answer is D. So placenta previa, we know there can be other risk factors like multiple pregnancy or smoking or IVF pregnancy or any previous termination or previous cesarean section. So the odds ratio after one cesarean, previous cesarean is 9.7. Now, when non-sensitized, okay, always remember to see if it's the woman is sensitized or non-sensitized. So the woman is non-sensitized Rh negative pregnant woman, and she is 34 weeks and she is having APH. She has moderate amount of vaginal bleeding. She is stable and the bleeding has stopped. So what is the specific test that you are going to order in her? Okay, so they are asking what's the buzzword here? What is the specific test for her? She is Rh negative. So she is having APH. So of course we are going to send the full blood count, coagulation profile, platelet count, all that we are going to send. But especially she is Rh negative and she has come with APH. So we are going to do the clay hot count. That is the clay hot test. The answer is D here. Okay, so apart from the other investigations, that is the specific test we are going to send in her, not an Rh positive woman, because here we want to see the amount of fetal-maternal hemorrhage, okay, because she has come with APH, and depending upon that antepartum hemorrhage, we want to quantify that, and we need to give the dose of anti-D immunoglobulin. Okay. Now we are done with the 10 SBA, so we will go to the extended matching questions. So here in extended matching questions, you will be having 12 to 15 options given, and out of that, you need to select, there will be a scenario, and then you need to select the single best option matching for that question. So here are the options given, and we need to select what is the most appropriate first line treatment, okay, from the above options. So we have the question coming. So she is a 38-year-old woman and she has a multiple pregnancy at 37 weeks of gestation. She was admitted in spontaneous labor at almost 9 centimeters dilatation. She quickly progressed to full dilatation and the first twin was delivered without any complications. Soon after, there was a brisk vaginal loss. Okay, blood bleeding was there, followed by bradycardia of the second twin. So what is the question asked here? To choose the single most appropriate first line option. So here, most likely the risk factor she had, it was the multiple pregnancy and the clinical scenario after delivery of this first twin. She had a brisk vaginal loss, so it points towards, and followed by a bradycardia, prolonged bradycardia. So here it points towards the abruption. And in this case, the first line option is the answer J, where we will do a emergency category 1 cesarean section under general anesthesia. Why general? Because the patient, we need to expedite the delivery here, and the epidural or any neuroaxial analgesia will take time. But in this case, we need to expedite the delivery. For that, the patient should have a category 1 cesarean section under general anesthesia. So here, in the second question here, we need to select the most suitable treatment option. Okay. So what is the most suitable treatment option? So here she is a 40-year-old woman. She is gravida 2 and she attends the triage at 32 weeks of gestation with suspected rupture of fetal membrane. So there is preterm premature rupture of membranes. This is her second admission. Okay, she has come second admission to the hospital. Why she had come first? She had come at 26 weeks with antepartum hemorrhage, which was settled, and that time she had received a dose of steroids, dexamethasone. And now the ultrasound scan shows a normal fetus with oligohydramnios, probably because she had rupture of membranes this time. So there is oligohydramnios. So what is the management for her? She's now 32 weeks with PPROM. And she had come at 26 weeks with APH and she had received steroids. So now what is the management for her? So here the management would be to give the answer would be C, that is antibiotics, that is erythromycin only. Why? Because we are once she has received a dose of steroids, so we are not going to repeat steroids because she has already received that. But she is a case of PPROM, so we will, if provided the maternal condition is satisfactory, she is not having any signs of infection, the CTG is normal, and the bloods are normal, showing no signs of infection, we can do an expected management till 34 weeks, after which she can deliver. But till that time, to avoid the risk of infection, we need to give her antibiotics, that is macrolides, after checking the allergy. The dose here, according to the Oracle study of the erythromycin, we give 250 mg 4 times a day for 10 days. Okay, so that has been found to be beneficial when the patient comes with PPROM, and that should be given. Now coming to question number 3, here we have to see what is the single most likely management option from the above options. Okay. Now here is a 28-year-old woman. She has come to triage with tightening at 26 weeks of gestation. So there is a case of a threatened preterm labor, but the hospital where she has come is a level 2 unit for neonatal care. And she is preterm. On examination, she is found to be already in labor. She is 3 centimeters and dilated cervix and bulging membranes. The CTG is normal and there are no obvious contractions on the tress. So what are we going to do here? So here we are going to do the in utero transfer. That is the most likely management option because it is a level 2 unit, and for a 26 weeks gestation, we need a level 3 or a higher care for a neonatal facility. And in that case, we are going to do an in utero transfer for the baby. Also, we need to, if there is option, we need to also give steroids for this patient for the when you are going to do an in utero transfer. So even if the delivery is not going to be delayed, but steroids should not be missed. They should be given because they can be found to be of some benefit if given. Now coming to question 4, here we have to select the what is the most appropriate diagnosis after reading the scenario. So she is a 16 years old, primary gravida. She comes to A&E with acute onset of back pain at 26 weeks of gestation. She is known to have a monochorionic twin pregnancy. She is tachycardic and hypotensive. Her abdomen is soft and there is no vaginal bleeding. Okay. So she is 16 years and back pain. So most likely from the clinical scenario, so here we can see that she can be there can be a concealed abruption. So answer here would be A. Because abruption can present with sometimes non-specific findings like back pain. There may not be vaginal bleeding always there if there is a concealed abruption, and sometimes the abdomen may be soft, may not be always hard, which is always seen. And because she is losing blood, she is tachycardic and hypotensive. So here the answer is abruption. So it can be the differential diagnosis if there is a back pain, which can be seen if especially if the placenta is posterior. Okay. Now here again, what is the most likely diagnosis? You can see the CTG here, where you can see there is a 34-year-old woman who presents to the labor ward with contractions and spontaneous rupture of membranes with vaginal bleeding. So she came with in labor. There was SROM, and after the rupture of membranes, there was vaginal bleeding. So on examination, the abdomen is soft in between contractions. So here you can see on the CTG, the baseline is not maintained, the fetal heart rate, and it is like a sinusoidal pattern, okay, which is seen in case of fetal anemia. So fetal anemia can happen in cases of vasa previa or any cases where fetal anemia is seen like in Rh isoimmunized pregnancies or a case of infections like syphilis, parvovirus, okay. So here there is a no specific history in this patient. So here the more, and it is written that it is after spontaneous rupture of membranes with vaginal bleeding. So here the most likely diagnosis could be a ruptured vasa previa. The answer here is C. So if the APH is associated with spontaneous or iatrogenic rupture of membranes, so it can be bleeding from a ruptured vasa previa that should be kept in mind. Now, the sixth scenario is where a 26 years old woman, she presents to the labor ward at 34 weeks with postcoital bleeding, that is APH. Her recent smear was normal. The CTG on admission is as follows. So you can see the baseline is maintained within the normal range of 110 to 160, but the variability is less. There are accelerations and there are no decelerations. So here she has come with APH and there was postcoital bleeding. So it can be due to a cervical ectropion also, where it is a cause of an APH. So the answer here is E, cervical ectropion. So they can come with APH, but still we need to take a full history and do the examination about the bout of when was or which episode it was of the bleeding, and was it a painless or the it is associated with pain, especially if the patient is having any associated hypertension which may point towards abruption, or a painless bleeding which may points toward or previous ultrasound showing low lying placenta. This all should be done and ruled out, and then examination can be done to see a cervical ectropion. Here we need to choose what is the most likely treatment that we are going to give for the next patient. So the patient is a 28-year-old nulliparous woman. She is 30 weeks of pregnancy and was admitted to the labor ward with a history of sudden onset of abdominal pain and no bleeding. Her pulse is 120 beats per minute and her blood pressure, if you see, it is 140 by 105. Her abdomen seems to be hard. So always she's 28 years null, primary gravida with 30 weeks of pregnancy, and she has sudden onset of abdominal pain, no bleeding. So it looks likely a clinical picture of abruption because her blood pressure is raised, and because it may be a concealed abruption because there is no bleeding revealed outside and she is losing blood inside. That's why she is having signs of hypotension like tachycardia. Her pulse is 120 and the abdomen seems to be hard. So it is most likely an abruption. So what are we going to do? So here we need to arrange, the answer is M, that is arrange an obstetric ultrasound to look for any concealed retroplacental clot. So most likely it's an concealed abruption, and our management, most important, will depend upon the fetal heart. Okay, so if the fetal heart rate, to confirm the fetal viability, we need to arrange a portable ultrasound scan. And at the same time, simultaneously, we need to resuscitate the patient. Now here are the different anti-D doses given, and we need to select what dose or what can be the management for this patient. So now this patient is a 20-year-old woman. She comes to the GP and asks for a termination of pregnancy because she had a vaginal bleeding 1 week back. Okay, and it shows that it's an 11-week pregnancy. She had a vaginal bleeding 1 week back. She was referred to the GP for termination of pregnancy. Okay, but she undergoes termination 2 weeks later. However, her blood tests were done that shows that she is Rh negative, and there are antibodies seen to the Rh negative antigen. So, what is the dose or what is the management regarding the anti-D? So here what we are going to do is, the answer correct here is there is anti-D immunoglobulin is not recommended for or indicated. Why it is not recommended even if she is Rh negative? Because she is Rh, because there are positive antibodies seen in resist D negative resist D antigen, meaning that she is already sensitized. Okay, so it is Rh sensitized pregnancy or alloimmunized pregnancy, in which cases we are not going to give anti-D. It is only given to non-sensitized Rh negative women. Okay, so they are given if they are having a therapeutic or that is medical abortion or surgical termination of pregnancy, regardless of gestational age, but it is not given in those patients who are already sensitized. Now coming to a 20-year-old woman, she attends the accident and emergence early pregnancy unit with mild vaginal bleeding, and she has just missed her period. She is in early pregnancy, her pregnancy test is positive, and the ultrasound scan shows that it's a singleton pregnancy of 5 weeks gestation, but her blood group shows that it is AB negative, and she has anti-KEL antibodies. So what are we going to do about anti-D? So because there are different antibodies like anti-C, anti-E, and anti-D and anti-K. Okay, so in this case, it is anti-Kel positive, in which case anti-D will be of no benefit in giving if the anti-Kel are positive, and hence the answer will be I, that we are not going to give anti-D for anti-Kel antibodies. Okay, because these are different antibodies, okay, than the D antigen. So here we will tell to continue the pregnancy, but to avoid any sensitization for D antigen, we will give her anti-D at 28 weeks, or we will give two doses at 28 and 34 weeks. This is the guidance by RCOG guideline. But now at present she is Kel positive, so we are not going to give her anti-D. Now, this is a 20-year-old woman who attends the obstetric day assessment unit at 21 weeks of gestation with minimal vaginal bleeding. Clinically, her abdomen is soft with no contractions. Her vagina, cervix, and vulva are normal. And the scan shows 22 weeks with an anterior low-lying placenta. And the booking blood test revealed that she is O negative blood with no antibodies. Okay, so she is non-sensitized. Okay, she is non-sensitized Rh negative pregnancy, and she has come with minimal bleeding at 21 weeks. Okay, so more than 20 weeks. So she is non-sensitized. So we can give her anti-D, but the dose will be different if she is more than 20 weeks. So if she is more than 20 weeks, we are going to give her anti-D of 500 international units. If she is less than 20 weeks, we can give a dose of 250 international units. That is according to the anti-D guideline. Okay. So I hope this helps, guys, and thank you so much for attending the antenatal module RRR series. Thank you so much.